Um, Hello everyone in the new normal life. Today I will be talking about microcephaly and macrocephaly. In everyday practice, when examining fetuses, we see small and big babies and small and big heads. Usually it's very normal and physiological, but sometimes it may be a very important finding. And what is difficult is to differentiate between the very normal ones from the very rare abnormal ones. So let's start to see how to manage these difficult cases. Okay. We usually consider microcephaly and macrocephaly as, I will make this small, okay. More than an infection or chromosomal abnormal, we usually consider it as the problem of the skull, but it's more than an infection or chromosomal abnormality. And usually it's more with malformations of cortical development rather than the skull deformity. When we start with the microcephaly, it is a head circumference significantly smaller than the average for the gestational age, and it's small brain rather than a small head. It's seen in almost 0.6 per 10,000 in newborns, but mostly develops by the age of 1 year. So it's almost 10 times more when the baby is developed to 1 year. It can be expected in almost 0.1% of pregnancies if fetal head circumference is normally distributed. Primary microcephaly is a condition where abnormalities occur at the early onset of brain development. It's usually a static developmental anomaly and it's present at birth. And when we are talking about the secondary microcephaly, it develops postnatal during infancy and indicates a progressive neurodegenerative condition. And we can talk about autosomal recessive primary microcephaly or microcephaly primary hereditary or microcephaly vera. It's frequently used in clinical diagnostics of microcephaly after birth, but it may be present in utero after 32 weeks. It appears to arise through failure of a normal developmental process and not regression or degeneration of established neuronal tissue. Infants are born with a very small head and a small but architecturally normal brain, and it is the cerebral cortex that shows the greatest size reduction. It's non-progressive and it may be caused by many genes. When we come to the pathogenesis of microcephaly, we know that progenitor cells in ependymal layer of the lateral ventricles are the precursors of neuron and glial cells. And if there's a reduction in the total number of progenitor cells, it will cause severe and lethal form of microcephaly. It's radial microbrain, it's called so. But what we usually see, it's microcephaly vera, and it's caused by decreased progenitor stem cell division. And as a result, we see reduced brain weight with either normal sulcal patterns or simplified gyral patterns or microlissencephaly. Diagnosis is very important for microcephaly, so careful measurement is very important, exact dating is very important. Fetal gender, ethnic background, parental size, and family history should be taken into account. So usually microcephaly in children or adults is defined as measurements 2 standard deviation below the mean. And we can do this for the fetal measurements too, but it's better to use 3 standard deviation, because when we use 2 standard deviations, almost 2% of the population is microcephalic. So we have very high false positive results. According to a very important study in 1984 by Chervanagan et al., and they retrospectively analyzed 16 fetuses with microcephaly. And when they used 3 standard deviation, it was very sensitive. There were no false negatives. And if you use 4 standard deviation, it's very specific and there is no false positives. So we can use 2 standard deviation, but it's better to choose 3 standard deviations. This is a good study. And if you take 3 standard deviations, the positive predictive value is almost 57%. And if the baby's fetal weight is also less than 3%, the positive predictive value rises to 66%. And if there is family history, the positive predictive value will be higher. We talk about the careful measurement because instead of measuring biparietal diameter, it's better to use head circumference. And as you know, there are different types of measurements. We usually use outer to inner measurement, but outer to outer measurement is used also. And there is moderate correlation between them. And there's a calculation that there is almost a 1 millimeter difference in, it depends on the gestational week, but there is almost 1 millimeter difference between them. So it can take a baby from 2 standard deviation to 3 standard deviation. So we could be careful about that. And we can use other measurements such as abdominal circumference or femur length, and we can use the ratios. But almost 50% of the microcephaly cases are small for gestational age, and for those, these ratios will not help. Extreme microcephaly may be diagnosed as early as 15th gestational week. However, most primary microcephaly cases are diagnosed in late pregnancy. A study done in 1999, almost 10,000 low-risk pregnancy patients were reviewed, and all 5 microcephaly cases were missed. Another study was done in 1995, and 6 out of 7 microcephalic children had a normal head circumference before 22 weeks. Even in high-risk cases with 25 to 50% relative recurrence risk, diagnosis may be impossible during the last weeks of pregnancy. It tells us that if we are trying to diagnose microcephaly, it may be not possible in the normal weeks that we are doing the fetal examination. And when head circumference is small, presence of increased amount of CSF surrounding brain, especially around the frontal horns and in the interhemispheric fissure, may be an indicator for microcephaly. When we come to etiology, and etiology may be detected in only as high as 57% of the cases. We see chromosomal abnormalities as much as 23%, and most common is the trisomy 13. There are more than 500 single gene defects syndromes responsible for microcephaly, and it's almost 20%. And we can see infections, and they are 6 to 16%. And the infections are cytomegalovirus, herpes simplex, rubella, toxoplasmosis, syphilis, varicella zoster, and as we all know, a recent one, Zika virus. Environmental factors, IUGR, alcohol, maternal phenylketonuria are also responsible for microcephaly. A microcephaly case may be isolated or complex. In this table, we can see the etiological agents which can cause a microcephaly. When we come to associated abnormalities, the anomalies can be directly related to the small brain. It may be a sloping forehead and the apparent large ear size and increased amount of extra-axial CSF. The anomalies directly related to the abnormal cortical migration may be lissencephaly, periventricular heterotopia, and dysgenesis of the corpus callosum. Other brain abnormalities such as cerebellar or brainstem dysgenesis may be found, and we can see some non-CNS anomalies. The risk of recurrence depends on the underlying cause. If there is a known defect in the family, it may be 25% if the transmission is autosomal recessive. If there is no history in the family, if there is primary microcephaly or microcephaly with simplified gyral pattern, it may be as high as 25%. The parent has microcephaly and has normal intelligence, then the transmission may be as high as 50%, but with normal or near normal intelligence. So when we come to the flow chart for the diagnosis of microcephaly, if the head circumference is less than 2%, 2 standard deviation or 3 standard deviation is better. Then we should look for associated anomalies. And if there is, then the prognosis according to the syndromic diagnosis, then we should consider amniocentesis, torch and HIV screening, Zika serology testing. We can do fetal MRI, and we have to refer to clinical geneticists. If there are no associated anomalies, we should look for consanguinity and family history, and we have to measure the head circumference of the parents and the siblings. If the familial head circumference is small, but they have normal intelligence, then the small head of the baby is probably constitutional, and it usually have good prognosis, and we have to follow up every 3 to 4 weeks. If there is a positive history of child with microcephaly and mental retardation, the recurrence risk is almost 100%. If there is no history and the parental head circumference are all normal, then we have to do fetal neurosonography, we have to do karyotype, and we have to look for torch and Zika virus infections. If the circumference is below 3%, then the risk of having a child with mental retardation is increased. So we have to do a fetal brain MRI. And if it's abnormal, if we see lysancephaly, simplified gyral pattern, then the mental retardation risk is almost 100%. If it's normal, then we know that the mental retardation risk increases with increasing standard deviation and increased severe of the microcephaly. So we have to follow these patients carefully. The prognosis, there are many papers about prognosis of microcephaly cases, and the neurodevelopmental delay or impairment in the gross motor, visual motor, language, and epilepsy are seen. Children with an head circumference between 2 standard deviations and 3 standard deviations are more likely to have learning disabilities with normal near intelligence. In children with microcephaly diagnosed during the first year of life, risk of moderate to severe mental retardation is increased from 33% to 62% when comparing children with head circumference between 2 standard deviations and 3 standard deviations, and those with head circumference below 3 standard deviations. And when we come to the macrocephaly, it's macrocrania or megalencephaly. Increased brain weight and the head circumference is more than 2 standard deviations about mean. And we have to keep in mind that the diagnosis of macrocephaly excludes head enlargement secondary to other causes, such as hydrocephaly, subdural hematoma, and tumors. Incidence of isolated macrocephaly is almost 0.5%, and it's usually diagnosed postnatally, may be caused by more rapid or prolonged time of cell replication or reduced rate of cell apoptosis, may be associated with potassium channel dysfunction. The total number of neurons are increased, and it may be isolated and or a part of syndrome, and they are more than 200. Almost 50% of fetal cases are due to familial benign macrocephaly. This form is isolated and relatively benign, and it's usually due to enlargement of the subarachnoid space. It may be autosomal dominant, recessive, or sporadic. Even in the autosomal dominant cases, inheritance is lower than the expected. The associated anomalies with macrocephaly, in order to see this, we have to do detailed sonography, and craniofacial anomalies directly related to the large brain may be seen, such as frontal bossing or increased amount of extrafacial fluid, malformations of the cortical development, pachygyria, polymicrogyria, periventricular heterotopia, and dyskinesis of the corpus callosum may be seen. We can see other brain anomalies such as ventriculomegaly, cerebellar or brainstem dyskinesis, or we can see non-central system anomalies, especially polydactyly and vascular malformations. And when we diagnose or when we are suspicious about macrocephaly, we have to ask ourselves that is it due to an abnormal growth, the overgrowth syndromes, or is there only a large head circumference? The overgrowth syndromes are a heterogeneous group of rare disorders characterized by generalized or segmental excessive growth commonly associated with additional features such as visceromegaly, macrocephaly, and a large range of various symptoms. Some of the overgrowth conditions are associated with predisposition to childhood cancer, so it's very important. The sonography findings, which are very important for us, are overgrowth. So we see macrosomia or macrocephaly. We see polyhydramnios, placentomegaly, and macroglossia. The differential diagnosis includes incorrect gestational dating, maternal gestational diabetes, as well as chromosomal abnormalities. Management of pregnancy should include level 2 sonographic examination and high resolution karyotype, and we can look for SOTOS, Simpson-Golabi-Behemel mutations, and if they are negative, we can look for Beckwith-Wiedemann syndrome imprinting disorder genes. And this is a table which tells us the syndromes associated with macrocephaly. What is important here is that most of the macrocephaly cases are diagnosed after 20s, so it's important. Usually they are diagnosed in the late pregnancy. For diagnosis, correct measurements, fetal gender, ethnic background, and parental head circumference are important as in microcephaly. Due to its development in late pregnancy or after birth, macrocephaly is usually not diagnosed during pregnancy, and when suspected in late pregnancy, anatomic and biometric evaluations are difficult, and if it is diagnosed in second trimester, risk of syndromic conditions is increased. There is no consensus for the exact cutoffs as in microcephaly. 2 standard deviations will automatically categorize 2% of the population as macrocephalic, and most fetuses with apparently isolated macrocephaly with head circumference between 2 standard deviations and 2.5 standard deviations are males, and most of them have normal head circumference at birth. A prenatal diagnosis of familial benign macrocephaly may be made when there is a family history and no associated malformations. This is the biggest retrospective analysis of the macrocephalic cases, and there were 98 fetuses which were diagnosed by 2 standard deviations. 82 of them were isolated and 16 were associated with other fetal anomalies. Macrocephaly was diagnosed earlier in the group B patients with additional anomalies, but it was 28 weeks, so it's very late. And associated anomaly group had larger head circumference, and the isolated group only have 1 infantile autism, but in the other group there were many associated findings, and there were cases with these syndromes. And according to this paper, they say that when fetal macrocephaly is associated with other brain or systemic anomalies, syndromic macrocephaly can be diagnosed in utero, and fetuses with syndromic macrocephaly have a significantly larger head circumference. It's usually more than 2.5 standard deviations, and isolated macrocephaly, particularly when the head circumference is less than 2.5 standard deviations, it's usually benign. The flowchart for the diagnosis of microcephaly is so, now, when the head circumference is more than 2 standard deviations, I cannot hear you.
Would you please sum up? Thank you.
Yeah. In 1 minute, I'm finishing it. If the head circumference is more than 2 standard deviations, we should look for associated anomalies such as ventriculomegaly, migration disorders, overgrowth, limb anomalies, polydactyly, and cutaneous findings. And if they are present, we should look for syndromes. If it is apparently isolated, and if there is no history, and the family are with normal head circumference, we should also look for overgrowth syndrome findings, and we can do fetal neurosonography, fetal brain MRI, and molecular evaluation. And we have to counsel according to the specific diagnosis. If there's a positive history, we should do the neurosonography, MRI, and the molecular evaluation again. If there's familial large head circumference, we have to do detailed physical examination for stigmata for autosomal dominant conditions. If it is positive, then we have to do the normal part, and if it's negative, then the prognosis is usually good, but we have to follow these patients carefully. MRI may be used for gyration patterns. Macrocephaly and thick corpus callosum on MRI may mean neurofibromatosis type 1 and macrocephalic capillary malformations. We have to be careful about this. The neurodevelopment performance at ages 2 to 4 years is similar between those who had macrocephaly, 2 standard deviations and 3 standard deviations and controls, but it may be associated with mental retardation. So take-home messages are microcephaly and macrocephaly are more than an infection or chromosomal abnormality and more with malformations of cortical development rather than skull deformity. Careful measurement, exact dating, fetal gender, ethnic background, parental size, and family history should be taken into account. 2 standard deviation is usually used, but 3 standard deviation is more specific. Most of microcephaly and macrocephaly cases are diagnosed in late pregnancy or in postnatal periods. So a normal fetal examination at 20 weeks is usually unable to diagnose most of those pathologies. Thank you very much.